Hello, my name is Bill Thomas, and as the Surgical Skills Tutor of the Royal College of Surgeons of England, I'd like to welcome you to this intercollegiate basic surgical skills course. As you will know, this is a mandatory requirement for all basic surgical trainees and candidates for the MRCS examination. The programme and materials have been approved by all the 4 surgical royal colleges, and the course itself consists of 3 modules: open surgery, trauma and orthopaedics, and minimal access surgery. Each module consists of exercises that have been chosen to demonstrate safe and sound surgical techniques. However, we would wish to stress that the course in no way seeks to impose or promote these techniques as being the only safe and sound way of performing these surgical procedures. Rather, we are seeking to teach one safe way that trainees may utilise, as it's very much easier to learn good habits early on in your career than trying to unlearn bad habits later on, which is a very difficult and painful procedure. Each exercise will be demonstrated by a short segment of video, after which you will have plenty of time to practice the exercise under the tutorship and instruction of your course convener and faculty. Throughout the course, you will be assessed as to how well you are grasping the principles demonstrated, and the aim of this assessment is to give you constructive feedback that we trust you will find helpful. We hope you enjoy the course, and we trust that it will provide you with safe and sound techniques that you will find valuable for the rest of your career.
The operating theatre is a potentially hazardous environment, and the surgeon has responsibility not just for the safe conduct of the operation itself, but for the safety of both the patient and staff in theatre. Last but not least is the surgeon's responsibility for his or her own personal safety within the operating room. There are many hazards within an operating theatre environment, but surgeons should be especially aware of those from sharp instruments, electrosurgery, ionizing radiation, and blood-borne infections. Electrosurgery will be dealt with in a separate part of the basic surgical skills course and will not be considered further here. Although ionizing radiation is largely the responsibility of the attending radiology staff, surgeons should be aware of the potential hazardous effects, ensuring that they take avoiding action and wear appropriate lead-lined clothing where there is a risk of exposure. The surgeon should also be aware of the general principles of infection control. These include hand washing, the use of protective clothing, the management of waste generated during procedures, and the cleaning, disinfection and sterilization of instruments and materials. These principles apply in the operating theatre as they do in all areas of surgery. We're all well aware that hand washing is important, but it is particularly important between each patient contact at ward level and in the operating theatre. Hand hygiene is something which most doctors take for granted, and is thus not given the attention that it merits. This slide shows the areas of the average hand which are typically missed during a hand washing procedure. It is particularly important during a surgical scrub that attention is paid in detail to these areas. To protect the surgeon from infection, it has been suggested that we should consider every patient an infection risk and embrace the concept of universal precautions. This means that the blood and body fluids of all patients should be considered infectious and appropriate precautions taken. This is a departure from the traditional practice of considering only certain individuals to be high risk, and a move towards a new practice where we identify high-risk situations in which the likelihood of contamination is high. This is particularly relevant in terms of transmission of blood-borne viruses to healthcare workers, and the commonest methods of transmission are shown on this slide. The risk assessment of patient encounters is shown here. In the operating room, there is likely to be contact with body fluids in most procedures, and a high risk of splashing in any kind of open surgery. Personal protection is provided in all operating theatre environments and should be worn by staff as appropriate to the risk of exposure. It should be noted that it is the personal responsibility of the individual to use the equipment provided. Failure to do so would prejudice against an individual in the light of any dispute. Notwithstanding the use of protective equipment, it is very important that surgeons and nursing personnel, particularly those at the operating table, take special care with the handling of sharps. Great attention should be exercised in the transfer of sharp instruments from one individual to another, and no two individuals should handle the same sharp instrument at the same time. This transfer is most easily achieved by placing the sharp instrument into a bowl or kidney dish for handover. Where a sharps injury occurs, and this will occur from time to time even in the best regulated of environments, it's important to be aware of the appropriate action that should be taken. The injury needs to be assessed as to the depth of penetration, whether the sharp instrument was clean or contaminated with blood, and in particular whether a hollow needle was involved in the injury. In this situation, it is important to assess the patient risk level. For example, is the patient a known intravenous drug user or known to carry a blood-borne virus? The injured area should be allowed to bleed freely and should not be scrubbed, as this may encourage deeper penetration of the contaminant into the tissues. The injury should be reported to the Occupational Health Service, and the injured party should undergo blood testing following appropriate counselling. If there is particular anxiety, the original patient may be considered for blood testing, but only after appropriate counselling and consent is obtained. In summary, the operating room is a potentially dangerous environment, with all the individuals within it exposed to risk. Simple precautions can minimise the risk to each individual and prevent cross-infection or injury to patients and staff. Surgeons should remember the importance of hand washing and adopt the routine use of universal precautions. Proper sharps handling should prevent injury, but in the event of an incident, surgeons should be aware of the proper course of action. The risk to all personnel in the operating theatre should never be underestimated. After adequately washing your hands, take one of the towels and dry one hand and then fold gently and sweep down to the elbow. Discard the towel. Take the other towel and repeat the procedure on the other hand, once again sweeping down towards the elbow and then discarding the towel. Pick up the gown and open it out so that the inside faces you. Insert both arms into the sleeves and allow the assistant to do up the back of the gown. It's wise to keep the hands inside the cuffs of the gown sleeves at this time, as we're going to perform a closed gloving technique. Once the gown is done up, your assistant will hand you the glove pack, which should be opened on a sterile surface. Take the gloves and use a closed gloving technique, inserting the fingers into the glove as appropriate, and then pulling back on the cuffs. Repeat the exercise with the other hand, again inserting the fingers into the glove and pulling back on the cuff until both hands are satisfactorily gloved, with no excess glove at the fingertips. Then hand the tab holding the posterior string of the gown to your assistant. Turn around and then tie both strings at the side with a bow. During this course you will be handling animal material, therefore it is essential to wear well-fitting gloves and aprons at all times. In the operating theatre, ensure that the gloves are pulled up over the cuffs. To maintain your fingers' sensitivity, ensure that there is no excess glove material at the tips of the fingers. When opening a suture package, tear it open as shown and remove the needle from the packet with the needle holder. Never use your fingers. Never pick up needles with your hands. It is important not to handle sharps directly like this. When picking up needles, use the needle holder, and then if you wish to alter the position of the needle in the needle holder, don't use your fingers, use the forceps to hold the needle and reposition it. Also be careful when tightening sutures that the needle does not do damage outside your field of vision. Therefore, when dealing with a long thread, don't simply pull at the needle, but use the middle finger of your right hand to grasp the thread, and then use your closed forceps to take up further slack. The suture material can then be tightened without the needle leaving your field of vision. Your suture material is then passed to your assistant, and the needle is now available for your next suture. When you have finished with the needle, do not lay it down on the patient or on the table, but pick it up and whenever possible dispose of it by cutting off the thread and placing it in the sharps bin provided. Never handle a blade with your fingers, but always use a hemostat as seen here. Slide the blade gently onto the handle. When it comes to removing it, just lift it off from the distal end and slide it off gently without jerking. Immediately place it in the sharps bin that is provided. Remember, when operating, do not have the table set too high or, for your back's sake, too low. The most comfortable position to operate in is one where your forearm is resting horizontally. When handling all instruments, safety and economy of movement is essential. Relaxed handling is needed in order to avoid awkward movements. Safe and effective surgery requires correct and safe handling of all surgical instruments and sutures. Please take time to acquaint yourself with the instruments provided. Let's first of all look at the scalpel. When handling the scalpel, you do not handle it like this or like this, as you don't intend to stab anyone. Instead, handle it in this manner, using your index finger to steady it. Then you can draw it gently and carefully across the skin, as you see here, in a controlled manner. Never ever cut towards your own fingers or thumb, as it may not just be the patient that you cut. When doing delicate work with a fine-bladed scalpel, you may wish to hold it like a pen. Then finer work can be undertaken. Note how the little finger can be used to steady the hand holding the scalpel. When passing a scalpel, never pass it blade first, but handle first with the blade down. However, the safest way is always to put it into a kidney dish and pass it to your assistant or scrub nurse. Now, let's look at the scissors. There are two types of scissors. One is more robust for cutting suture materials, and the other is finer for tissue dissection. Let's look at how to hold scissors. Hold them with just the tips of the distal phalanges, with thumb and ring finger in the rings, steadying the scissors with the index finger and the middle finger. Never put your fingers right the way through,
as this makes it difficult to extract your fingers from the instrument. However, by using just the distal phalanges, you get very good control for accurate dissection. If you're cutting sutures at depth, such as in the pelvis, it's often wise to stabilize the instrument over your index finger. This allows for accurate cutting and prevents a tremor down a deep, dark hole. We now move on to the forceps. There are two basic types of forceps. One is the non-toothed, the other the toothed. If we take the toothed forceps, such as we see here, these are often used for tough tissues such as skin, while the non-toothed forceps tend to be used for more delicate tissues such as bowel. Hold the forceps as you see demonstrated here, and not grasped in your fist like this. By holding them gently, you get accurate control of the tips of the forceps. Now, let us consider the hemostat. Correct handling of the hemostat is critical. Pick it up much as we did with the scissors, using the distal phalanges, and, as one is opening them, put pressure on the thumb against the ring finger and middle finger, and then the hemostat opens gently in a controlled manner. If holding it in your non-dominant hand, you might wish to hold it in this manner, and then put pressure from the middle and ring finger against the thumb and index finger, and open the hemostat in a controlled manner. Watch again. Pressure from the middle and ring finger against the thumb and the index finger, and it opens smoothly. Do not let the hemostat jerk, as this can do damage to any blood vessel it might be holding. Finally, we come to the needle holder. As mentioned previously, always pick up the needle with the forceps, then pick up the needle holder in a similar manner to the scissors and the hemostat. Place the needle holder about 2/3 of the way around the circumference of the needle, as you see here. Do not place it too near to the tip or the rear of the needle, and place it in the jaws of the needle holder as demonstrated. Insertion of sutures requires a smooth supination of the forearm, but occasionally a backhand suture is required, in which case the needle position can be changed in the needle holder, enabling you to insert a backhand suture. This is an exercise of forearm manipulation, with one arm pronating and the other supinating synchronously. Watch again. One arm is pronating while the other arm supinates, and therefore the needle can be changed from the forehand to the backhand very simply and efficiently. Using the jig provided, practice tying a standard two-handed reef knot as seen here. At the end of the procedure, you can see the classic picture of a reef knot as clearly shown by the different colour threads. We will now tie one in slow motion, demonstrating once again the features of tying a two-handed reef knot. Ensure that the threads end up at the opposite side of the jig to which they started, and snug down the throw securely. Then repeat the throw, coming back again, ensuring that the threads end up at the opposite side of the jig to which they started, to ensure that the knot lies correctly. Once again, the classic picture of a reef knot is seen. Take the short end of the suture in the hand that you'll be using for tying, and if it is away from you, we use the index finger knot. This is tied as shown here, taking it under the other length of the suture. Then go back, use the middle finger knot, and then snug down. And once again, we see the classic reef knot picture. We will now tie one in slow motion. Take the shorter end and tie the index finger knot as seen here, bringing the black suture under the white one and then securing and snugging down by pulling the black end towards you. It is essential in a reef knot that your hands cross with each knot, and that alternately an index finger knot and a middle finger knot is tied. Here is the middle finger knot being tied, and this time the black end of the suture is taken away from you as you tie it down. The same principles apply when tying a reef knot with instruments. Take the instrument and with one throw over it, grasp the shorter end of the suture and gently pull it through and snug the throw down. Then do an opposite turn, again grasping the end of the short suture, pull it through, and you see the classic picture of a reef knot emerging. Let's now demonstrate some common faults in knot tying. A satisfactory reef knot requires alternating throws of index finger and middle finger knots, crossing the hands with each throw. For example, if we do an index finger knot, but don't cross our hands, we will not have the correct throw for a reef knot. Alternatively, we could do the correct throw one time, but then tie the same type of knot, the index finger knot, and although we cross our hands, still not have a reef knot. Here we see an index finger knot being correctly laid, and a middle finger knot being correctly made, but the hands not crossing. And again, we don't end up with a reef knot. Let's therefore remind ourselves of the correct way. Index finger knot. Crossing the hands. Middle finger knot. Crossing the hands again, and here we see the reef knot. One other common fault is for the surgeon to hold one end of the suture up and tie round it, and although they may appear to tie alternate knots and cross their hands, they are actually tying round the suture, and you can see the white thread runs straight through the knot, resulting in what is virtually a slip knot, and the white thread can be withdrawn. This is therefore not a secure knot. Always remember to cross your hands, as you see here. For added security, 2 reef knots may be tied on top of each other. Occasionally, we want a knot which is secure and will not slip even with one throw. Therefore, we can tie 2 throws, as seen here, and snug that down, and then return by 2 more